TMD is one of those things which is like so debated, so hotly contested, so controversial, right?
Taking these broader categories, like how do these typically present in practice to you during an exam, or does it chop and change for every patient?
I tell them, I'm not a guru, I don't know what's going to work, but can we at least try things that are conservative, and then we can always escalate to more aggressive things. Welcome back to another Protrusive Students episode. Emma is back after finishing her finals exam. So in Glasgow, where she studies, you do the finals exams in your 4th year, and so she'll be soon heading into her final year, which is 5th year. So it's strange that they do their final like academic exams in their penultimate year, but I guess that's how it works there. And I'm pleased to say she passed. She passed, and she's back again for this series called Protrusive Students. Now, it's not just for students. It can be revision for someone returning back into dentistry, or validation for many clinicians, or maybe you're feeling that TMD is not your hot point, and so this is a great basics episode to lift up your foundational understanding. Now, it's very tough to cover TMD in this short episode, but the main takeaway I can tell you now is the hierarchy of treatment, or management is probably a better word than treatment. We do talk about a few clinical gems and a few pertinent points in someone's history, or the common mistakes we make when we're palpating the joints and the muscles. But if there's one thing that you're to take away from this foundational episode on TMD management, is the hierarchy of treatment and why it exists. What are the modalities included in conservative care, and what are the modalities that are deemed more aggressive, and why we should have a bit more logic and sequence to how we treat our patient. You'll be able to download my hierarchy underneath the link if you're on the app, and of course for all the students out there who have exams coming up or want some really good revision notes, Emma regularly updates the Crush Your Exam section. So in this section on the Protrusive Guidance app, you can access it on your phone or on your browser, anywhere you like, and you can download revision notes. For example, PS016 was indirect restorations, a really good overview for young practitioners and students. And for this episode, you're gonna get everything about TMJ anatomy, which is so important. How can you understand what pathology is if you don't understand what normal anatomy is? So to access that, just head over to protrusive.app, make your free account, and join the Are You a Student section. If you can verify you're a student, you just need to DM Marie on the app. Her name is Marie Benitez. She's like our CPD queen, also student lead. She'll just need some proof that you're a student, and she'll let you access the Protrusive Vault, which has got like all our infographics and papers. It's our way of like supporting and nurturing you students. But like I said, this episode is also useful for those who have a bit more experience, who are qualified, and you can even get CPD or CE credits for this episode. We are a PACE approved education provider. For that, you need one of our paid plans, and you scroll down, you answer the quiz, and Marie, our CPD queen, will arrange your certificate. Let's now join Emma, the Protrusive Student, and welcome her back for this episode. Emma, welcome back to Protrusive Student. Congratulations for passing your finals. Like in Glasgow, you do it in the 4th year. Tell us, how was it?
It was intense, but I made it through. I think anyone that's done final exams before, you've just got to keep your head down for a bit and get through it, really. But I survived, so here I am.
Never in doubt, Emma, never in doubt. I remember we were chatting before you getting results, and it's sometimes difficult to gauge how you've done. Like, I was convinced I failed. Like, it was like one of the OSCEs went that bad, but actually I did end up doing very well. And so it's a bit of a family joke now about how I catastrophize and that kind of stuff. But it was all good. And what is now that you've been through it, what's the number one advice you can pass on to someone who's going to be maybe doing finals next year, for example, or coming up imminently?
I would say don't underestimate anything, because they will just ask you anything. Question bank.
You're supposed to make it like, you're supposed to make them calm and reassured that's going to overwhelm them like to the nth degree, but it is what it is.
I think you can either be one of two people. You're either going to be someone that knows a little bit about everything, or a lot about certain subjects. So for me, I'm one of those people. I like to know a little bit about everything. There's not one specific topic that is my absolute ride or die, or something that I'm bagging on coming up in the exam. I'm one of those people that like to try and cover everything.
And that's the best strategy, right?
I would say for me, definitely, yeah. But I know some of my friends, they pick the topics that are quite common year after year, and they will know them inside and out, and they will compromise on the other topics that they just don't have time for, because you're never going to know absolutely everything unless you're you and you get 100% in your finals.
That was one exam. But with you, what's the pass percentage?
I think, like in Glasgow, I think it's around about 60.
Okay, in Sheffield, it was 50%. If you get 50, you can be a dentist. Which coming into it like from A level, right? And like as a 19-year-old and going to dent school, and then you get told that, hey, you just need 50% to become a dentist. And I
Yeah,
was like, wow,
yeah,
okay. But it's tough, right? That's
yeah,
why
it
honors
is.
is 65%. And then you get
Yeah,
your 50%, you're like, whew, phew, that was hard
yeah,
kind of thing, right? And it really puts you in your place. But I think the most important thing is they want to see that you're a safe beginner and that you're
mhm,
going to go out, because it epitomizes the fact that dentistry is something that you really learn once you qualify
yeah,
rather than in dental school. And so good. I'm glad you got through that. Today's episode, we're talking about something that I like to talk about. We've done episodes for dentists in the past, but today we're going to make it very student specific for you.
yeah.
TMD, TMJ, TMD. How much of the previous episodes on TMD have you listened to? How much information about TMD have you consumed? I know you've got a really good tutor in Glasgow, Dr. Ziad Al Ani, who does wonderful work with occlusion TMD. So I imagine your knowledge is better than the average student, I imagine.
I think Dr. Alani is like absolutely amazing. We have him a lot in first and second year, and then when we come back to do a lot of TMD and oral medicine in fourth year, we go to Dr. Rob Riley. He's an oral medicine specialist. So I think they teach us a lot. How much is examinable and relevant for new graduates? Unsure, but it's all things that you need to be aware of. We go pretty in depth for TMJ, TMJD, big topic in Glasgow for exams and things.
So I'm thinking that you probably know more than the average student about TMD. So, like, how much background knowledge is there something that you're lacking confidence on, or you are feeling confident on? Like, where's your headspace around TMD?
I would say for TMD, it's one of those ones I quite enjoy, especially working for Protrusive. Like it's something that you like to talk about, you talk about quite a lot. So working with you for the last few years and editing those episodes and doing all the notes in them, it is something that I think I have a bit of more of a background on, but it is a big topic, big
But
topic.
like, it's one of those things, right, where yes, you learn about it, and then you read some articles about it, you go to the books, but then when you have that patient and they give you
Yeah,
this history, and then you're like, whoa, what's the diagnosis? And then you think, okay, how do I manage this? It's one of those things that I think is one of the most difficult things to
yeah,
apply. And Jeff Oakson, I'm literally staring at his textbook in front of me. He says that TMD is a thinker's game, right? It very much is it's a bit like ortho, right? Like it's all the planning, the brackets, fine, they go where they go, but it's all about the planning and the sequencing and the
yeah,
diagnosis and that kind of stuff. So really, I want you to ask away any questions that you think will genuinely help you and students everywhere. And we can, yeah, I think it's nice to go back to basics, but here's an
yeah,
interesting, I'll just set the scene a little bit, right? TMD is one of those things which is like so debated, so hotly contested, so controversial, right? And I say this to my patients when they come to me and they expect me to be this like, or this guru that's going to cure them. I am very quick to educate them that, hey, if you go to 7 different practitioners, they'll give you radically different. So it's not even like slightly different. Like if you have a broken tooth, it's either going to be a crown or a filling, right? Very rarely, or someone might say it's restorable, not restorable, right? But like it's going to be a crown or a filling. You for TMD, like you have jaw pain, you can go to someone, they will say you need ortho. You can go to someone and say you need Botox. You can go to someone and say, you know what, just go physio only, you'll be fine. And so it's a really tough space to be a patient in general anyway. It's a very debilitating disease. It's very, very debilitating, has a huge impact on the quality of life on our patients. But it's also more troublesome because as a patient, that you are trying to read up on it and you're like, whoa, like I'm so confused. There's so much out there. And then it also gets carried through as a clinician because we then
yeah,
have, there's not just 2 polarizing camps, it's about 5 different polarizing camps. If you listen to Daniele Manfredini, one of my friends, Morton, he went to his like a live thing in Italy and he will get very, Italian hand gestures and he will bang the table and he says, occlusion has nothing to do with TMD, right? And then he will put the splint in and just send the patient away saying, because why? Because the occlusion doesn't matter, right? Whereas I'm training with Dr. Robert Kirstein, who's coming to the UK in September. Hopefully, we're organizing that. And he's going to give me, hopefully, what we call DTR certification, which is basically disclusion time reduction therapy, which is basically adjustments of teeth, of their own teeth, to get them onto canine guidance as soon as possible. Okay. And you monitor it using these EMG things. And so what he's saying is occlusion is everything to do
yeah,
with TMD. And so I'm looking at these 2 camps and I'm like, whoa, And then the other three camps are lurking in between. And then there's a gazillion different types of splints. So no wonder, Emma, it's confusing. How can I help? Where do you want to start?
So, as students, we get so much thrown at us, just information to remember and to recite in exams. But in dental practice, and I understand you probably see a lot more TMD patients than the average, what are the most common temporomandibular joint disorders seen in dental practice?
Okay, so if you can just categorize them broadly into three main categories, there are lots of subcategories. So TMD is an umbrella term, right? It's a bit like, I give the analogy of, like, for example, if I say someone has perio disease, we automatically think of like pocketing and chronic perio disease, but actually perio disease encompasses like a traumatic occlusion causing mobility. That's a type of perio disease. It could be periodontal disease around an implant, so periimplantitis. It could be perio disease in the form of recession. They don't have any like mobility, don't have any pockets, but they got loads of recession. That's a type of periodontal disease, right? And so periodontal disease has lots of sub-classifications and diagnoses. And so TMD has lots of sub-diagnoses. So if you look at the actual official research diagnostic criteria of TMD, there's like 13 or 15 different sub-classifications. But they're broadly speaking, it's muscular. Okay, so it's extracapsular. So basically, the capsule is that piece of anatomy that sort of encompasses the ball and the socket, i.e. the condyle and the fossa. So everything that happens in that space to do with the disc. And that's intracapsular. Extracapsular is everything outside of that. So we're thinking muscles, right?
Yeah.
And then there's osteoarthritis. So this is like classically bone on bone. It's like a wear and tear disease. So if you look at those three, then the most common is muscular, right? 70%. And then it's like a 25% intracapsular. So this is like clicking, locking, clunking, popping, that kind of stuff. Very similar terms used on purpose. And then there's osteoarthritis, which is like degenerative, right? So over the years, there's been wear and tear, and you classically get crepitus. They open and close their mouth, and you feel this like crunching in their jaw joint, but classically, they don't have any pain. And so, yes, there's crossover, right? You have all three at once, or you have muscular with intracapsular, but those are the broad ones, and muscular is the most common.
The most common, yeah. So I suppose this is also a very broad question, but taking these broader categories, like how do these typically present in practice to you during an exam, or does it chop and change for every patient?
It can be. So TMJ, right? It's called the miracle joint, which is Dania Tamimi came on the podcast and said it so elegantly. But it's also, TMD is called the great imposter. Did you know that? So you can have like,
I've heard you say that before.
Yeah. So you can have like many other issues like tinnitus and headaches and vertigo and all that kind of stuff. But actually, it's your TM joint is the main culprit. So it's a great imposter for that reason. So how does it present? We'll put it this way. Because I get referrals for TMD and patients seek me out for TMD. And actually, as a clinician, I'm happy to say this. I know patients watch my podcast, which I wish they didn't, but they do. And I'm happy to say that I'm happy to help. I'm empathetic. I'm sympathetic. But I'm no guru, right? I try and follow the best evidence available, which isn't that great anyway. So I try and do things in a way whereby, okay, let's do the most reversible and basic things, safest things first, and escalate from there. And the peak of that would be surgery. Okay, so very few people need to escalate to that. Lower down is Botox. So anything that's irreversible, like orthodontics, we save that until we've exhausted, like, education, physiotherapy, and appliance, that kind of stuff, right? Now, going back to your question, how do people present? And the reason I mentioned what I just mentioned now is when I used to be purely a general dentist, and I would just do a TMJ examination and I would diagnose, do you know you have a click? Or, oh, your muscles are quite sore, aren't they? And so that was not a symptom. It was a sign. A sign is something that we find, but the patient hasn't quite yet. It's like subclinical. And so success rate was through the roof because actually it's not become a big problem yet for them, right? But now when patients seek you out for this care, then quite often they've had it for a long time. It's very debilitating. It's like trying to help someone when they got small carious lesion and it's completely asymptomatic. So you know that the risk of root canal is so low versus they come in and they're already in pain And so, pulpitis has started. There's a higher risk of root canal treatment ensuing. And so it's more difficult to treat. It's more difficult to preserve pulp vitality. So I'm making that comparison because when I now see my patients, they have very clear like headaches, jaw clicking, jaw locking. Whereas when you have general patients, they often have zero issues. A really good study to look up, Emma, for all our colleagues listening. So it was the OPERA study. I think it followed like 3,000 or 4,000 healthy people who did not have TMD, right? It followed them up and they saw who got TMD and who didn't. Really fascinating, right? Prospective study. And then they kind of looked at they studied the people who did get TMD and they found like commonalities. Now, they didn't really go into the occlusion kind of things, but it was like genetic testing. They were often quite in a high state of stress. They had a few other things, like they had like tummy issues like IBS, they had genital symptoms, they had other like back pain, muscular aches around the body. So there was like common trends in these patients. So what that can teach us, that it affects a very specific kind of person. And in my practice, and also according to the literature, it's like 8-to-1 females to males, 8-to-1. So we know it must have a genetic or hormonal component if that's the case, right? So it's that kind of a patient that can come to you. And I think one tip I can add is that if that patient comes to you and they're complaining of a jaw issue, then Schiffman found a really cool way to figure out, okay, is this patient's concern more muscular or more joint? So is it intracapsular or extracapsular? Is that you get the patient to say, can you point with one finger where the source of pain is? And if they point right by their ear, then it more than likely probably is intracapsular, something to do with the capsule, the disc, the clicking, clunking, that kind of stuff. Or if they're pointing all over their face or lower down, then it's probably muscular. And that can help you to kind of figure out where to delve deeper into in their history.
Okay, yeah, that's some good like wee clinical tips because, just when you're starting out as a student, you're just feeling, and you're kind of blind at that point. You don't really know what you're looking for. So that's some good wee tips there.
What you mentioned there, what you're looking for, the top tick in this basics episode is classically when me and Krina, the physiotherapist I work with and taught with in the past, is when we're calibrating dentists on palpating muscles and palpating the joints. Classically for the TMJs, we are too far anterior. We're like feeling the zygomatic, we're kind of feeling your cheekbone, right? We need to go a little bit closer to the ear, right? And then when you get the patient to open a bit and wiggle side to side, you should feel the balls of your condyle. Can you try that for me, Emma, right? Can you put your middle fingers, let's say, just in front of your ear and then open a bit and wiggle your jaw side to side? Did you feel the balls of your condyles like against your fingertips? You're in the right place now, right? Whereas classically, if I don't do that wiggle bit, classically dentists are too far forward. The other thing I found is that when dentists are palpating the muscles, and we'll talk about that if it leads that way, we're being too gentle. We need to really be a bit more thorough when it comes to muscle palpation. And so it's very difficult to talk about something that I want to talk about so much about, but I'm also mindful about keeping this in tune with relevant for early career people or students, or actually this could be a good revisiting for someone getting back into practice or someone who actually feels though, they ought to just get the foundations of TMD. And so far what we've said is it's an umbrella term. It can present in loads of different ways, but classically muscular is the most common, but obviously there can be like clicking, popping. We can talk about the mechanism of that as well. And just to like calibrate, like make sure you're palpating the right place and you're able to at least locate the condyle and check the mouth opening. And I guess we can talk about the key things to record, but I want you to lead the show, Emma.
Yeah, I mean, the next question I was going to ask you was, we start basic patient education and you can go all the way up to surgery for treatment options, and it obviously depends on the diagnosis. Should we dive into that sort of treatment options?
That sounds great.
Yeah.
Let me share my screen. So for those who are listening on Spotify, don't worry, we're going to describe it. But there's a really cool thing that I want to show, which is like a really nice pyramid that I've been working with, which I also share my patients, that I show them, okay, this is where we're at and this is where we're heading. And this is how we manage temporomandibular disorders. We don't treat TMDs, we help to manage TMDs, and they kind of get it and they understand why. A really good thing that Jeff Okerson teaches is that, okay, there's things that we know are like evidence-based, even though the evidence-based quality can be poor, and one of the reasons it can be poor is because there's so much variability, Emma. Like your joint anatomy will be different to mine, just ethnically, genetically. You're a woman, I'm a man. Your tooth contact time, how many minutes a day your teeth come together is different to mine. Your incisive classification is probably different to mine. And so one of the reasons why the research is so different is because it's difficult to compare and get good research quality basically in that regard. But it's nice to be able to educate in terms of, okay, why we follow a certain hierarchy, because as Jeff Oken says, okay, let's try and focus on the things that are reversible. But then if you're treating someone and you're doing what we call fringe treatments which are not really evidence-based, it may be perceived as maybe a little bit naughty, a bit irreversible, like orthodontics, but at least you've tried all the basic things first, because that could have helped. But then also, at least you know, okay, what I'm doing is on the fringe, and to know you're doing it. The worst thing you could do is do hocus pocus dentistry that isn't evidence-based, but you don't really know that you're on the fringe. You know, that's one of the worst places to be, is what Jeff Okerson teaches, and I really respect that. Okay, so where we start is patient education, right? One of my mentors, Jameson Spencer, he taught me that TMD patients are nuts. Right? Okay, they're nuts. Okay, what I mean by that is not what you think. It's nuts means not understanding their symptoms. That's what nuts means. Okay, so just we owe it to our patients to educate them, okay, about the anatomy, about what's going on, because believe it or not, there's a handful of patients every year I see that just by education, I don't like to use the word cure, but I manage them. Okay, they literally are really help. And even like sometimes telling the patient that our teeth shouldn't be touching together during the day, and they're like gobsmacked. They're like, "What? I thought our teeth should be touching together the whole time." And once you tell them that, and then they're there in the chair, they're clenching away, and when you tell them that, hey, you know, this is pathological, this is not good, and then finally, after so many years of their life, they're able to give their muscles rest. That's it. They're essentially managed. Right? So we owe it to our patients to give them an explanation. Sometimes the patients are they don't really are not in pain. They're just scared. Like, wait, what is this clicking? What's happening? Am I going to need surgery in the future? If you just explain to them what a click is, and we can talk about that, then this is why education is the foundation. Okay. So any questions on that before we move to the next bit?
In terms of education, sorry?
Yeah.
Not in particular, no.
Okay, so the next thing is soft foods, because we have to remember that the temporomandibular joint is indeed a joint, right? So if you have something, a dodgy knee, well, you're going to go, crutches or put less load on it or not do strenuous activity. So when people are having a flare-up of their TMJ, so for example, their joints themselves or the muscles, it just makes sense to eat, as we had recently on an episode as well. Dr. Susie Bergman said, eat smaller, eat softer, eat slower. Right? Smaller, softer, slower, the 3 S's. So it makes sense because it gives the joint rest. So we educate our patients to do that. And as part of education, we also say, our teeth shouldn't be touching together. And like I said, that can be very curative for a lot of patients. We tell them what a click is. So a click, Emma, do you know what a click is? Like, what is that click sound? What does that mean? What's happening to your disc?
Is that the disc displacing?
So when I open, okay, so what does reducing mean?
So reducing means it's going back into its original position.
Lovely. And so what Dania Tamimi came on the podcast maybe a few episodes ago, and she had this wonderful way of explaining it. Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at it, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode. Think not of disc displacement with reduction, because reduction is a confusing term. Think of it as disc displacement with recapture. By using the word recapture, it really is like a light bulb moment, don't you think?
Mm-hmm. Yeah.
So when you open and that click comes, that's not what a lot of people think. Even prosthodontists, I know, have thought this, is that they think that click is bad and that, oh, your disc is dislocating out of position because that click sound means it's dislocating. No, that click means is that the disc is already out of position, and that click is the disc returning back onto the condyle. It's the sound energy of that motion. And so actually it's a disc displacement with recapture. And so just going back on the education bit there, the next bit in the hierarchy is, TMD education, soft foods, and then ice and or heat. So heat is really good for muscle, but sometimes they need to experiment and they do like hot and cold or just cold. Whatever makes them feel good is a simple, cheap, minimally invasive, evidence-based way to help sore muscles and reduce inflammation. The next one is gentle stretching, because a lot of times your muscles can be in spasm, and when muscles are in spasm, to allow them to have stretching is really good, and to actually go forward towards jaw exercises, like very specific exercises, and then in tandem with physiotherapy. Physiotherapy has got some decent evidence base when it comes to TMD. Chiropractors, on the other hand, don't have it. So, like a patient the other day asked me, I found a good chiropractor. Should I go for them? I'm like, yeah, you can, because if it's going to help my patients, and if my patient thinks it's going to help them, then that's great. I'm happy for it. But if you have to spend good money, then why not do the more evidence-based thing first? Try the physio first, knowing that the chiro is probably a little bit more on the fringe. And so it makes sense. And so physios can be incredibly helpful. Like my physio I use, Krina, in central London. She does dry needling. She does red light therapy. She does very carefully targeted exercises. And that can actually improve their range of motion. So initially they might be opening 32, 35 millimeters, okay, without pain. And then after her physio, they're able to get, a 20% improvement in their range of motion. So that's there. Anything there before I escalate to the next two, which are more conservative?
I was going to ask about like all these stages and about soft diet. So are these things that you would do, the first two in tandem and then you would review after a certain period of time, or would you just take it step by step by step?
Yeah, really good question. I think it depends on who's in front of you. But
Yeah.
most patients, right? Because these are all basic things.
Yeah.
Like you can do TMD education on everyone, okay? If they're actively in pain and the one their complaint is that it hurts to chew hard foods, then soft foods it will be a mainstay. Ice and heat for those in pain, but sometimes the patient's not in pain. They're just like they're getting lock without any pain at all.
Yeah.
There's no pain. They're just locking now and again. So for that patient, you may not be necessarily saying, okay, put ice and heat because they don't have any pain. But it's more about then giving them specific exercises to strengthen certain muscles to help their coordination, to help them unlock themselves at will. So like you can't go wrong by knowing these, but you might pick and choose a few of these and emphasize more on certain facets of this on certain patients than others. And that kind of depends on the micro-diagnosis or the problems that your patient presents with.
Okay, that makes sense, yeah. And about the physiotherapy as well, how, like, just out of curiosity, how often are you sending patients to physio?
I would say 80% of my patients would benefit from physio.
Okay.
Because it's like a lot of times if I send to physio, then we may not even need to do an appliance. Like it just makes sense. And finding a good physio is really tough because there are physios who dabble in TMD. And so they're taking knowledge from other joints and they're applying it to the TMJ, which can help. But I encourage patients to try and seek out specifically TMJ specialist physiotherapists. And because in physio school, you don't learn above the neck, actually. Yeah. Right, so you need to seek out physios who are specialized in TMJ. So it's actually not just like seeing a physio, but specifically a specialist really helps that.
Okay, that makes sense. Yeah.
Next one is medications. So NSAIDs, ibuprofen, for example, if the patients can tolerate it. Maxillofacial surgeons may recommend baclofen, which is like a muscle relaxant, something I don't really prescribe, but it can be used as well. So medications have their place. And the last part of conservative care is an appliance. In fact, and there's mixed evidence when it comes to appliance therapy, but the most recent randomized control trial, this was literally published June 2025. So this is like 2 weeks ago. So it's in Cranio, which is a highly respected journal, and it's effects of occlusal splint therapy in addition to physical therapy on pain patients affected by muscular TMD. This was a randomized control. So diagnosis was extracapsular muscular TMD, and the patients were allocated into the experimental group, which is basically education, physiotherapy, and splint. That's the educational group. And the control group is education and physiotherapy. So you always have a control and then you have an intervention. So the intervention they're really testing here is, does the addition of a splint actually help? And actually, this is not the first time this study has been done. I've seen previous studies done like this and they found the splint made no difference. So again, evidence-based really varies, but this is a really recent one in a highly respected article. So let's talk about it. The primary outcome was TMD pain intensity. And all outcomes were assessed at baseline, at the end of physio, and after 6 months at the end of physio as well. So there were 27 subjects, 7 males and 20 females. So 27 is not a huge amount, but in these randomized controlled trials in TMD, it's difficult to recruit, and this is quite often in TMD literature you find that the N numbers are quite low. So let's go to the conclusion. Okay, findings from the present study demonstrated that pain, NDI, which is Neck Disability Index, and health-related quality of life improved in both groups. So that's good. So we know that if you just do education physio, you're going to improve your muscular patient, right? But only in the experimental group, which was the splint group, these outcomes improve significantly further after 6 months. So at like a few months, they're both working, but at 6 months, then actually there is a lot of merit in having an occlusal appliance. Thus, our results show that adding occlusal splint therapy to the physical therapy may produce higher positive effects in patients affected by myogenous TMD. So there we are. That's hot off the press research. Happy to that you asked me that, because I'm able to talk about this, and hats off to the authors. And then I'll put that paper, link that paper in the show notes. So that's why I think it has a place, because if there's bruxism happening, if there's wear facets, right, and they're overloading their joints, then it sometimes makes sense to put something in between their teeth to prevent that load being transferred onto their joints, and they're kind of like protecting the joints and protecting the muscles.
For sure. And I know you mentioned there about splints and bite therapy. What do you offer? Because I know there's so many different types of splints and a lot of opinions on different types. So what do you use in practice?
I think in the interest of time, I think I'm going to say, if anyone's really interested in this, it's a rabbit hole to go down, right?
Yeah.
So the evidence base will say that there is no one splint that rules them all. I feel as though I've refined some protocols and I've got enough patient data now of my own that I do think certain splints are better suited to others, but this is not high quality evidence, obviously. But remember that when it comes to N=1 case studies, in the world of adhesive dentistry, you have all these like benchtop studies, in vitro studies. Something that one of my mentors, Lane Ochi, taught me is that even if you just have one case report, N=1, one case report, okay, involving a real patient, that's already better than any in vitro study ever done.
Yeah.
Because that involves a real patient, right? So I think there's a lot to be said about that. But if anyone's interested going down this rabbit hole, 2 resources I can link to this podcast. One is a flowchart I made, which pretty much summarizes my decision making in appliance therapy when it comes to permissive splints. These are splints that are not guiding the jaw anywhere, and the jaw goes wherever it wants to go. Think of soft bite guards, think of Michigan splints, think of hard occlusal flat splints, that kind of stuff. So I'll link that, make sure, Emma, that we link that flowchart. And also, I did a couple of episodes, which is the best splint. There was actually a whole episode about that. So I think let's direct our listeners to go down this rabbit hole. I think everyone needs to do their due diligence. But in a nutshell, if it's a muscular patient, I find something like a B splint quite helpful, which essentially the back teeth are not able to touch. So if you try it on yourself, Emma, can you clench on your back teeth and put your fingers on your like forehead region over here, just side of head, lovely. Bite together on your back teeth and tell me what you feel on your hands.
You could feel like your muscles protruding there.
Did you feel a bulge? Did you feel a bulge on both sides or just one side?
Both sides.
So you have already more than likely a healthy masticatory system, because a dysfunction patient is basically their bite's so off that when they bite together, one side bulges and the other one doesn't, or it bulges asynchronously. So one side bulges and then like a second later, the other one goes. Okay. So if they bulge at the same time, that's good. And then feel your masseters. Can you go and feel by like the angle of your jaw, a little bit lower down for me, a little bit lower down. Yeah. A little bit. Yeah. And now bite together and feel the bulge there. Yeah. Do you feel that? Okay, good. So a certain type of splint that when you are clenching together, you're not able to contract. It's a bit like if you hold a pencil in between your front teeth and you try checking those muscle contractions again, you'll feel a small fraction of that power. So I find splints like that are really good for the muscular groups, basically, to just to give some sort of value to that. So after you've done all that conservative care, conservative non-invasive care, so conservative, once again, TMD education, soft foods, ice and heat, gentle stretching, jaw exercises, physiotherapy, medications, and an appliance therapy, specifically appliance that does not aim to change the bite, then what you do is you evaluate, okay? And then after the evaluation, and then you see, is the juice worth the squeeze? Are the risks of aggressive treatment worth it? And then the aggressive treatments, which we're not going to go into in this a more basic episode, but is bite adjustment, orthodontics, crown and bridge work, and surgery. Okay. And then encompassed within that as well is Botox and stuff, right? That's a little bit more aggressive. It's like the interface between conservative and aggressive. I would say Botox somewhere in the middle. Which kind of paralyzes the muscles. But that's kind of the mainstay of how we can, in the absence of high quality data, manage TMD. Any questions on that?
So you show this to your patients, don't you?
Yeah, I basically talk them through it. Because the problem with TMD patients, bless them, They've often been fobbed around, and they are, like I said, they're nuts. They're not understanding their symptoms, and they've been down this dreary pathway of researching everything, and they are really confused at what's going on. And so they already have like preconceived ideas. And unfortunately, there's so much marketing to these TMD patients, and then messages like, hey, you need ortho, hey, you need this approach, hey, you need Invisalign to cure your TMD. And so bless them, they're so confused. And so I say that, look, maybe that is the right way. I don't know. But this is what I believe in, because I tell them I'm not a guru. I don't know what's going to work. But can we at least try things that are conservative? And then we can always escalate to more aggressive things. And that to me goes like that for me is a rational way to explain it. And my patients understand it. I think the way I explain that, they get it. They understand that I'm on their side. I don't want to go straight to surgery unless it's genuinely needed. I don't want to go straight to Botox unless we can do patient education and physio first before we escalate. And I think my patients have received that really well.
Yeah, and I think we learned similar in Glasgow, start off with the basic things, the obvious things, and work your way up. But even for me, I'm struggling with, or was more so when I was stressed during exams, struggling with grinding and a sore jaw and things like that. It's calmed down a bit now, but even then it was just, me as a dental student still just didn't really know what to do about it. So there's so many opinions in TMJ and TMJD, so it's a hard one. But yeah, definitely that flowchart as well that you were talking about just lays it out nice and simple as well.
Great. So we'll make sure we reference all those. And I think one more nugget I can give to make it as valuable for everyone spending time listening to this. But like you mentioned, you were stressed, right? And so stress is something to do with it as well. You are probably clenching your teeth some more, so muscular overload. And then a really cool clinical tip I can give you is if the patient says their pain is worse in the mornings or the pain is worse in the evenings, that gives you a clue. So if the patient's waking up in pain, then that could be the overwork, the dental gymnastics happening in the night. But if this pain, like they feel great in the morning, but by the end of the day, their muscles are really burning, then that could be something that's what we call awake bruxism. And the interesting thing about bruxism is that, fascinatingly, bruxism is not even linked to TMD. We haven't even established those links. So let's not even go down that rabbit hole just yet. But for some patients, it can be a big deal, because muscles get overloaded. But if someone is even thrusting their jaw forward, like holding their jaw forward without touching their teeth, that's still bruxism. That's still a pathological thing. So what we end up doing, especially as dentists, we're like, in this strange posture, and we speak to dentists all the time, their jaw is in this funny position. And as dentists, we suffer a lot with TMD, muscular TMD ourselves. And so it's about making sure that you are respecting your jaw posture. You're keeping everything relaxed. You're not holding tension in your jaw, because that could be a big part of your TMD story. Because even you, transiently, you had TMD. You had muscular TMD by the sounds of it.
Yeah, and it wasn't until recently that I really noticed it. We were doing intraoral scanning at uni for, like, at the end of our exams, we go back for a few weeks. Dr. Matheson said to me, he was like, oh, 100%, you grind your teeth in your sleep. And then I have a partner now, we've only been together like a few months, and he was like, you grind your teeth in your sleep. I woke up one night and I was like, what the hell is she doing? And I was just like chomping my teeth away. So that's not actually something that I was ever aware of either. But I notice it now, so I'm trying to stop.
Wow. Okay. So interesting. Let's talk about that, because when you tell patients, right, it's like, we call it grind scene investigation. Okay, GSI. Okay, not crime scene, grind scene investigation. Because when I was newly qualified, I say to a patient, "Hey, you grind your teeth," and you know what patients say? Like, "No, I would know. I would know if I grind my teeth." Okay?
I would know.
My partner would have told me, right? Kind of thing. But here's the thing, right? I think it's like kind of like catching a solar eclipse, seeing your partner grind, right? You have to wake up at that exact moment in time. It's dark, okay? You wake up at that exact moment in time. You often don't make any sounds when you're grinding. And then how many minutes a night are we actually grinding? Okay, it's like 8 to 15 minutes for a severe bruxist. And so to catch that, the few seconds of bursts of grinding activity, that's why the patient, like when you ask patients, if you grind your teeth self-reported, then the incidence is low. But if you look at the wear sets, the incidence is high. So actually go by the grind scene investigation. So you never say to a patient, you grind your teeth. You say this, you say, patient, did you know that you had the signs of teeth grinding? So you, as a dentist, we take control, because either they don't know that they had the signs of teeth grinding, or they do know that they had the signs of teeth grinding, right? It's not like a blame thing. It's like, hey, you got the signs of teeth grinding. Okay, this is the grind scene investigation. Therefore, you have been, right? So it may not be active, but I can see evidence of it, kind of thing. So maybe we have to do an appliance for you, Emma, and we can talk about that. One thing we're introducing to Protrusive is pathways, right? Because I noticed we got so many hours of content on our podcast now. And I feel as though we want to invite everyone. Like, if you want to go down the TMD rabbit hole, we probably have like 12 to 15 hours you can consume just on TMD and have like a mini diploma in that, right? And be able to help your patients. So what we're going to do is I'll link below the playlist for all the Splint and TMD type, Bruxism type episodes that you can go down the rabbit hole. But similarly, like everything around bridges, everything around onlays and crowns will have its own pathway. So we'll release these pathways by the time this is published. This will be out there. And so I would encourage everyone to delve deeper. And hopefully this is like a nice little, wet your feet and an introduction to TMD. We could go days and days talking about this, right? But it's one of those things that it would be nice it's nice to have this conversation, but I think it'd be a disservice if we try and just distill all of it. But now we can lead them to the pathways which are available for free. Obviously, if you want to get CPD, then join one of our paid plans, help support Team Protrusive and what our mission. But any burning questions, Emma, based on our chat just now?
None at the moment. I think that was good for me as well to maybe learn a bit more at the end there about my own possible problems with my TMJ and my pain that I'm having at the moment. But no, it was good. A good reintroduction, definitely.
Good. And maybe you can do a part 2 next year and build on this. What else do we have any student notes? Like you've been uploading your student notes in the Crush Your Exam section of the app.
Yes. So I've made some student notes for TMJ, not so much TMJD, but more just about the TMJ cavity, movement and
anatomy.
Stability. Yeah, anatomy.
Perfect. I was just going to say that the top tip I'd give to everyone starting out is learn the anatomy. Like it's so crucial. The muscle insertions and origins, what the disc looks like, because that is once you understand the anatomy, you can understand disease. Mechanical disease is relevant to TMD, and sometimes it is. So that's a really key one. Also, in the future, if you're doing bigger cases, reorganizing the bite, it's important to have this knowledge to be able to assess a healthy joint, which will allow you to proceed to give that level of care.
100%, yeah. So a lot of anatomy, and then just at the end, there's a very small, like, basic understanding of TMJ dysfunction, just a very small bit there.
Amazing. So if you guys want to catch that, check out the Protrusive Guidance app. The website is protrusive.app. It's free. If you message Marie on the app, then she'll be able to get you onto the secret student section, which gives you access to Protrusive Vault as well. But Emma, what have you got planned for the rest of the version 2, season 2 of Protrusive Students, now that you're a free woman?
So again, a free woman at the moment. Again, just going through, I actually have a list of potential topics. I know that we just did one on communication, and we've got a lot of episodes on oral medicine, but maybe just a student version, oral med, oral surgery, medical history. We've not done anything on endodontics yet, but just some basic understanding of those kinds of topics. So
it sounds great. Okay. I'm excited. Let's do it. So whatever you decide, and whatever serves the students the best, we will do it. And thanks for the wonderful notes that you make for us. And I'll see you next time. Thank you so much.
See you next time. Thank you.
Well, there we have it, guys. Thanks so much for listening all the way to the end. Like I said, you can download the PDF of the TMD hierarchy on the Protrusive Guidance app. Just head over to protrusive.app on your browser, and then once you sign up, you can then actually download the Android or iOS app. But it's really important to make your account first. For the students, you got your own space, but for everyone, we're a very inclusive community. As long as you're a dental professional, we are here to support and grow together. We are the nicest and geekiest community of dentists in the world. That's like our tagline. And if you listen all the way to the end, like you have done, and you are a real qualified dentist, I use the word real because recently in the news, there was like this Czech dentist who was like fake, and he was like YouTubing procedures procedures and he got away with it for a few years. That's absolutely crazy. But anyway, if you're a real dentist and you want to get CPD and CE credit, this episode is eligible. You can get over 350 hours of CE on the Protrusive Guidance app, from clinical walkthrough videos to our bread and butter episodes. So do check it out. And remember to share the love. If you find that this podcast is helpful to you, your colleagues, your associates, your mother-in-law, if she's a dentist, might find it helpful as well. So please send it to everyone. And I thank you once again for sticking with us all the way to the end. I'll catch you same time, same place next week. Bye for now.